Hi, thanks so much for having me. I'm Amanda Lynett. I'm a registered dietitian with the University of Michigan, the Division of Gastroenterology and Hepatology, and I'm going to be talking about dietary therapy for EoE. So one of the main causes for EoE is an adverse immune response to foods that drives these eosinophilic inflammation up. So that the goal of dietary therapy is to induce the disease remission by removing the food antigens. And then after that, you systematically put the foods back in to identify what is the trigger to avoid long term. This is a great option, for individuals that don't want to take medications that is just kind of masking or reducing the inflammation. This is getting kind of what we say, like the root cause and removing what is causing the inflammation in the first place, those food antigens, rather than treating the inflammation that already exists with medications. Research has shown that dietary therapy can be as effective up to 90%, anywhere from 35 to 90%, and we'll talk about those different dietary therapies in a moment. This can be a first-line treatment option, so patients don't have to fail other therapies to try this out. Options for dietary therapies. The oldest and most research is the elemental diet, which was found to be upwards to 90% effective. And then there's the empiric elimination diets, which include the 1-food elimination, the 2-food elimination, 4-food elimination, and 6-food elimination. As you can see, I highlighted in red here like a meta-analysis that kind of showed these different dietary eliminations and their overall effectiveness. So the 1-food is got about a 46%, the 2-food is about a 45% average, 4-food 54, and 6-food 65. So it does show that least restrictive elimination dietary options could be considered as a primary treatment option. So you don't have to start with overly restricting and then adding things back in. You can start with least restrictive. And then as far as allergy testing and elimination diets, these are not recommended at this time. They're not found to be as effective with very mixed results. What am I referring to when I'm talking about these different elimination diets? The 6-food is referring to removing of the top 6 allergens. So that would be removing dairy, wheat, which sometimes verbally we interchange that with gluten, eggs, soy, peanuts/tree nuts, they go under one category, and then fish/shellfish, which go under one category. A 4-food would be removing those top 4 allergens. So we are removing the dairy, the wheat, the egg, and the soy. The 2-food is just the dairy and the wheat, and then the 1-food would be dairy. So dairy is the most common allergen that has been found in research. So that is why that was what has been studied to be the 1-food elimination. I'm going to talk through some of the pros and cons. I will go into more details about this in a moment, but it just shows that, the pros for a more restrictive approach could be you have the highest response rate, you have a highest percentage of getting into remission. However, it is the most restrictive, the most timely, it requires the most number of scopes. And then as you go down, like with the 1-food, it is the least restrictive option. It impacts quality of life. So I think it's best for individuals and their quality of life to restrict less foods. But there is a possibility of lower remission rates and then having to go upwards, which we'll talk about in a moment, and further restricting the diet, which could be daunting or lead to individuals not wanting to continue dietary therapy and switch to other options. So the 6-food elimination is the most studied. It was first studied in 2006, following, research on elemental diet. And a 2023 systematic review found that it led to about a 61% remission of where people were having their histologic remission, their eosinophilic count was less than 15. A 2024 meta-analysis found roughly about the same, about 64%. And then a 2025 American College of Gastroenterology guidelines state that it has, depending on the research study you're reading, anywhere from 40 to 70% efficacy as far as remissions. So within that, the researchers were finding that the most common triggers were milk, wheat, egg, and soy, and that people seldom had the nuts or the fish allergens. So they thought, do we need to pull out all these 6 foods and have to reintroduce them, or could we go into a least restrictive option? As I briefly mentioned in the chart overview a couple slides ago, utilizing the 6 food elimination is good in the sense of it has the highest remission rate. It is about 65% chance to 70% chance of getting into remission on that first go of removing the 6 foods. But if you remove the 6 foods, you are going to have to do more reintroductions, which means you're going to have to do more scopes. We cannot go off of symptoms for reintroduction and how a patient is feeling. We have to do repeat EGDs, those endoscopies. And so that is a long process. It can be costly, and it can lead to people not wanting to follow through with the diet, or it increases the risk of, cross contaminations or poor adherence to the diet because you're following a more restrictive diet for a longer period of time. So I feel like the 6 food elimination is best for a highly motivated patient, someone that enjoys cooking, someone that is not has good access to food and to the kitchen, isn't traveling a ton, or a college student living in the dorms that can't prepare their own food and might have very limited options if they're removing too many food items. That would not be a good option for that individual. Since the 6 food was so well studied and it found, like I mentioned, those top 4 foods, the milk, the wheat, the egg, and the soy, as the most common food antigens that triggered the EoE, there has been further research on a 4 food elimination. And systematic reviews showed that it has about roughly a 50 to 55% efficacy. So it's a little less effective as a 6 food, but it still can have really good results for you. So what are some of those benefits for that 4 food? It's less restrictive. So you still, if you don't eat meat and you're removing some of those other protein sources with soy and egg and dairy, you can now still eat your nuts and fish. So it's least restrictive, more diet variety. It requires less repeat scopes. So because you're removing less foods, that is 1 to 2 less repeat EGDs you're going to have to do, which can save some individuals some money. So throughout research, milk and wheat continue to remain the most common EoE trigger foods, prompting more systematic reviews and research on the 2 food elimination. To the 2 food showed efficacy of about 45%, which is actually slightly lower or about as effective as a 1 food elimination, interestingly enough. So I think some positive things about eliminating just 2 foods to start off with, it helps with patient buy-ins or your willingness to try a dietary approach because it's less restrictive up front and can possibly shorten that diagnostic period. So it may be easier, for those with those busier lifestyles. I was talking about the college student. This might be a better option for someone to do the 2 food elimination versus a 6 food elimination. People still have good response to it, so that is a good option, and it can have a better impact on quality of life. The disadvantage is because it's only about a 45 to 50% remission rate, there's a possibility of not responding, which means that you're then going to have to longer eliminate foods and have further restrictions. So because I keep mentioning that dairy was the most common food allergen, they did some research on a one food elimination, which would be removing just dairy. One study I want to point out compared a one food elimination of dairy versus the six food elimination. So that would be that milk, the dairy, wheat, soy, egg, the fish and shellfish, and then nuts and tree nuts. Uh, and they found that 34% of individuals removing just the dairy got into remission, and versus 40% on the six food elimination got into remission. So that's not a huge difference. You know, a lot of people still got a remission just removing one versus removing six, of 34% versus 40% at 6 weeks. Now, this was done at 10 different sites throughout the US on adult patients, and they did do a phase 2. So the individuals that did not respond to the diet on the one food were offered to advance to a six food elimination for an additional 6 weeks. So a total of 12 weeks of eliminating foods. And then those on the six food elimination that did not respond to the dietary therapy were offered topical steroids, and they could do fluticasone twice daily. So after the additional 6 weeks, so that's now 12 weeks of elimination, um, 43% of individuals on the diet, additional individuals on the diet, responded, and then an additional 82% of the six food responded to medication therapies. So it shows that, you know, if you do the one food and you don't respond, I encourage you to further step up and remove more foods and repeat a scope, because a 43% like chance of further getting it if you don't respond is a pretty high chance. That's 50%. Um, they further studied this comparing a one food versus a four food. Another study, this was with pediatric patients, and they found similar outcomes. So the results were very similar as far as remission rates, and quality of life scores were very similar, if not a little bit higher in the one food elimination. So there is a good response to eliminating one food, and this could be a wonderful option for a lot of patients. So I feel like I already talked about some of the advantages of a one food elimination. It could shorten the diagnostic time, the less scope someone has to undergo, and unnecessary restrictions. I guess the only disadvantage would be the lack of robust research on this, and also if someone doesn't respond, that does prolong that elimination period where people are having to remove foods for a longer period of time. So instead of just maybe 6 to 8 weeks of removing something, they're now looking at 12 plus weeks of removing foods. So I feel like this is a good picture to kind of show what I've been talking about. I've been talking about removing all of these foods up front, those top 6 foods, and then having to slowly put the foods back in. So someone removes the 6 foods, they get their EGD, it's less than 15, then they add back in fish, and then repeat at EGD, and then they add back in nuts, repeat EGD, and then so on and so forth until they've added all the foods back in. They need to reintroduce the foods for about, roughly we say about 2 to 4 weeks, and then repeat an EGD. So that's up to 7 scopes with removing 6 foods. That is a long time. You know, that could take up to 42 weeks to fully reintroduce things. Where this step-up approach, where I was talking about only removing 1 or 2 foods, there is a chance, like a better chance of you being in remission, right, after those 6 weeks, and then you only have to remove one or reintroduce one food if you removed wheat and dairy, and that process is now looking like 12 to 18 weeks versus 42 weeks. There's potential to shorten the process with that step up approach versus the step down, where you remove less foods up front versus removing more foods down up front. So things to think about and consider when choosing your dietary path. So I keep talking about this reintroduction after elimination. I'm talking about the 6-food elimination, the 4-food elimination, 2-food elimination, 1-food elimination. But the diet doesn't stop there. We need to identify your food trigger to minimize those unnecessary food avoidances. So it's not, hey, go follow the 6-food elimination and just live the rest of your life that way. No, we need to reintroduce foods one at a time, and then you have to repeat an endoscopy. Symptoms don't always correlate with the degree of inflammation. So in the absence of other reliable biomarkers of disease activity, we really have to do a scope to really truly tell if someone is responding to the food or not. There is a lack of research on the length of reintroduction period, so how long to do it. So it's best, to talk with your provider about the timing of the reintroduction. That varies by practices. I know at my institution, we typically do 4 to 6 weeks, and we have the individual consume that challenge food daily. So we're trying to basically, we cleaned out their system, they're in remission after removing all the food antigens. Now we're going to take one in particular, we'll say egg, and we want you to eat 2 eggs every single day and then repeat your EGD in 4 weeks and see if it causes an increase in inflammation again. We want to challenge it versus only consuming eggs once a week because we don't know how much of that food antigen, how much of that food someone has to consume in order to cause an increase in the inflammation in the eosinophilic count. So if you aren't consuming enough of it, it might give you a false negative after 4 weeks. So the more you consume in this challenge phase, the better. It doesn't mean you have to consume that much after this period. If the scope is negative, you can go back to consuming it how you typically would. So just one more time to kind of drive home the point of dietary therapies, these empiric elimination diets for EoE. This is kind of how it all looks like. So you eliminate the food. So whatever food path you take, whether it's a 1-food, 2-food, 4-food, or 6-food, you eliminate it for roughly 6 to 8 weeks. That varies by, your discussion with your provider. You repeat that EGD. If your count is less than 15, you're a responder, and then you add that first food back in for about, like I said, that varies also. We do 4 to 6 weeks at our institution. Repeat EGD. That if that food is less than 15, that's a safe food. Move on to the next food. If that is more than 15, if that is a trigger food for you, you're going to want to do a washout period. So you're going to want to remove that food for a few weeks before you move on to the next food, and so on and so forth until you get through. You repeat that cycle until you've reintroduced everything. Now, if you don't respond right up front, if your numbers are still greater than 15, then we would consider you a non-responder, and you would want to further eliminate foods from your diet or switch to, some medication treatment option. So I feel like this is a wonderful slide that kind of drives home the whole process so patients can really visualize how long it takes and what goes into the process when they're making their decision. I think understanding this is important up front during the decision rather than say, oh yeah, I'll try 6-food elimination. I respond to it. I'm have improvement and my eosinophilic counts are driven down, I'm in remission, and then afterward being told about this reintroduction phase. So I think people need to understand the whole picture before choosing dietary therapies rather than being told it halfway through the process. Just wanted to briefly touch base about some potential barriers to compliances. So Dr. Chang and colleagues did a large survey of potential barriers for compliance. And when it came to dietary therapy, the inconvenience of the diet was a potential barrier, more commonly in adults than pediatric patients, which makes sense. There's more social obligations, stigma, things of that nature that could be playing a role. Another barrier was undergoing multiple endoscopies, poor quality of life, and socialization. And then with the pediatric population, there was a concern or a potential barrier with the inadequate nutrition. Access to a dietitian could be a potential barrier. I think having a dietitian could help solve some of these other um, barriers. They can help with making sure a patient is getting the adequate nutrition they need to prevent any nutritional deficiencies. Now, there is no actual research or studies on long-term deficiencies because the diet is only meant to be followed for so many weeks before identifying your trigger food. That should not be a risk. But if someone does identify that dairy is their trigger, we need to make sure that a patient is getting other sources of calcium and vitamin D. So that's where a dietitian can help with giving a patient the alternatives for long-term maintenance. Other potential barriers could be diet-related anxiety, food fear, food avoidances. I think those are some things to kind of think about. So, the right patient for the right diet. I think success with an elimination diet depends on both the patient selection and the ability to execute the eliminations and the reintroduction phase. So a patient has to be motivated or have a desire to undergo dietary therapy. If you do not desire eliminating foods from your diet, then this isn't the right pathway for you. Individuals' personal preferences, values, their lifestyle, living situation, ability to adhere to restricted diet, their age, should all be considered as well, and their willingness to have the frequent endoscopies and travel, as well as the financial or insurance coverage. If there is a high deductible for EGDs, but maybe checking with your insurance plan to see um, if they will be covered is a common thing that we recommend here within the United States. So dietary therapy for EoE should be individualized. This should be an open discussion if you are a provider with your patient to discuss all the options. If you are a patient, I hope this taught you have better understanding of your options for dietary therapy and what you could talk to your provider about. Be aware that there are other IgE mediated allergens. Someone might have environmental allergies that are driving up their eosinophilic count, so that also plays a role into why not everyone responds to it. It is one of the main root causes, but it's not the only root cause, and we don't fully understand the other environmental allergens. So if you are someone that has a lot of environmental allergies, keep that in mind. That could play a role in your response to dietary therapy. I think thinking about too risk, anyone that's at nutritional risk, if there's at risk of a disordered eating disorders, if someone is already malnourished and underweight, maybe dietary therapy isn't the best option for them, or a least restrictive approach would be best because we don't want to further put them at risk for nutritional deficiencies. This is not meant to be a weight loss diet. I always tell people if someone loses a ton of weight in those 6 weeks of removing these allergens, then we weren't doing it properly and we weren't swapping out foods properly to make sure they were still getting a nutritionally adequate diet and getting everything they need. We don't want to be pulling from your muscle stores and everything. Another thing to really think about is the potential risk of cross-contamination. I didn't get into this very much, but we treat this like an actual food allergen. It is not just, oh, if I occasionally have it during those 6 to 8 weeks, it's not a big deal. No, we want someone to strictly remove all of these foods during this experimental time because we are so closely repeating that EGD that we really want to decrease any variables or any potential causes for the eosinophils to stay elevated, and we want to drive down the inflammation in this short period of time. And then other aspects to kind of think about is how to navigate your life, like talking with the dietitian of what are your restaurant options? How are you going to travel? Questions to ask when you go to family gatherings, again, to decrease that risk of cross-contamination. There are some wonderful resources out there. There is a publication that's open to the public, done by Dr. Chang, myself, and some other colleagues, that has some things to be thinking about when you're navigating these social situations and professionally. So in summary, dietary therapy for EoE can be an effective first-line treatment to control eosinophilic inflammation. Despite these challenges that can occur, like the impact of quality of life or restrictive diets, I find that dietary therapy are increasingly popular option as a treatment that patients might desire. The right answer depends on the right patient. So we shouldn't be telling patients they have to do the 6-food. I think it needs to be a shared discussion with our patients to help us decide what pathway is best. And dietary partnership is really important. So if you plan to undergo a dietary therapy for EoE, working with a dietitian is very important. Thank you so much for your time. This is my email if you need to contact me. Take care.